Module on the gastrointestinal tract. The gastrointestinal tract begins in the oral cavity and goes all the way to the anus. It's the conduit through which our food passes and nutrients are absorbed by the body. From a gastrointestinal point of view, however, you can basically divide up the GI tract into 4 different areas. The first is the esophagus, the second is the stomach, the third is the small intestine shown here, and the fourth is the large intestine. And so in this module, we're going to go through these 4 areas one at a time. Each of those sections of the digestive tract has 4 layers, and they all are named the same thing. Whether you're in the stomach, small intestine, or large intestine, you can find a mucosa in each portion of the GI tract. You can find a submucosa, a muscular layer, and a serosa in each portion of the GI tract. On the bottom left is a picture of the stomach zoomed in to show you the 4 layers. So the stomach has a mucosa and a submucosa, followed by muscle layers and a serosa. On the right side of the screen is a cross-section of any one of the layers of the GI tract. There's always a lumen in the middle, of course. That's followed by a mucosa and a submucosa, and then a muscular layer, and the serosa is always on the outside. Also take note that the submucosa has a nerve plexus, and so does the muscular layer, and we're going to talk about these 2 nerve sections as we go through this module today. So the most superficial layer of any portion of the GI tract, the part of the GI tract that is connected to the lumen, is called the mucosa. And all the mucosas in the GI tract have 3 sections to them. The first is the epithelium, which is the surface layer that absorbs nutrients. This is followed by a lamina propria, which is for support, and as we'll see, it has many important structures in the stomach and small intestine. In the stomach, it has the gastric glands, which secrete stomach acid. And then outside of the lamina propria is a muscularis mucosa. So this is different from the muscular layer of the GI tract. This is a muscular layer within the epithelium itself. And in this picture on the bottom of the screen here, you can see the layers. Here we've got the mucosa, and that has an epithelium right on the inside, followed by a lamina propria for support, and then a muscularis mucosa. Outside of this entire mucosa layer here, you can find the submucosa, and outside of the submucosa, you can find the muscularis layer, followed by the serosa. The next deeper layer beyond the mucosa is the submucosa. This is a layer largely of connective tissue. It also contains an important nerve plexus called Meissner's plexus, which is also sometimes called the submucosal plexus. And the key clinical tie-in here is a disorder called Hirschsprung's disease. This is a disorder of the rectum and the colon where children are born lacking in Meissner's plexus. I talk about this disorder in more detail in the module on intestinal diseases. Beyond the submucosa, the next deeper layer is the muscular layer. This layer consists of smooth muscle on top of other smooth muscle. There's an inner layer that is circular, so it's a circle like this. Then there's an outer layer with longitudinal fibers going in this direction, and they both work together to contract and propel food through the GI tract. In the muscular layer, you can find another nerve plexus called Auerbach's plexus. It's between the layers of smooth muscle, and the key clinical tie-in here is the esophageal disorder achalasia. People with achalasia have difficulty swallowing food, and they have problems with Auerbach's plexus, and I talk about this in more detail in the modules on esophageal disease. Finally, the outermost layer of the different portions of the GI tract is called the serosa. This surrounds every layer of the GI tract, and it is a layer of surface epithelial cells called a mesothelium, and it secretes lubricating fluid. And when you get to go into the operating room as a medical student, hopefully you will get to handle the stomach or the intestines, and you will see that they are slippery. And the reason they are slippery is because the mesothelium of the serosa is secreting lubricating fluid. Now, structures that are in the retroperitoneal portion of the abdomen are a little bit different. They are not surrounded by a mesothelium. Instead, they are surrounded by something called adventitia, which is a layer of loose connective tissue. And they are a little bit different in that they are not lubricated like the other portions of the GI tract. Now what I'm going to do is go through the different sections of the GI tract, the esophagus, the stomach, the small intestine, the large intestine, and talk in a little bit more detail about each portion. And we'll begin with the esophagus. And for each section of the GI tract, what really distinguishes it from the other sections is its mucosa layer. And the mucosa of the esophagus is the simplest one to understand. It is stratified squamous epithelium. This is a picture of it over here. It's relatively straightforward to recognize because it doesn't have some of the more detailed structures we'll see in other sections like villi and crypts and Peyer's patches and things like that. This is non-keratinized, stratified squamous epithelium. I also want to show you how to identify the esophagus in a CAT scan. On the left side of the screen is a CAT scan of the chest. These black areas are the lungs on both sides. Contrast material has been injected to fill the vascular system. Therefore, the white structures in the center of the screen are vascular structures. This circular one at the top is the ascending aorta. This circle at the bottom is the descending aorta. Between the two, this is the bifurcation of the pulmonary artery. The aortic arch is not seen. It's at another level.
if we were at the level of the arch, you would see the arch connecting the ascending and descending aorta. In the back of the chest, there are two black holes. One I'm circling with my pen here is a circle. The other one is sort of a collapsed, funny-looking structure here. So anything that's black must be filled with air and not blood, because everything that contains blood is white because of the contrast material. So these two structures contain air. The circular one here is the trachea, and the trachea has a rigid cartilage around it, and therefore it maintains its circular shape. Behind the trachea, you can see the esophagus here. The esophagus is not rigid and it collapses, and therefore it usually doesn't have a perfectly circular shape. So you should be able to identify in a CAT scan of the chest the ascending and descending aorta, the pulmonary artery, and then be able to find the trachea and the esophagus right behind those vascular structures.
Now let's talk about the stomach, and let's start by defining the different anatomic portions of the stomach. The cardia is where the esophagus connects to the stomach. It's where the epithelium changes from stratified squamous epithelium, like we saw before in the esophagus, to columnar epithelium, as is found throughout the stomach. The fundus is the upper portion of the stomach. The body is the main portion of the stomach. And then the last portion of the stomach is called the pylorus, but it's traditionally divided up into the pyloric antrum, which is the portion of the stomach that connects to the pyloric canal. And people often just refer to the antrum of the stomach, meaning this area that connects from the body to the pyloric canal. And then the pyloric canal ends in the pyloric opening, which is surrounded by muscle called the pyloric sphincter. After that, you have the small intestine starting with the duodenum. The epithelial layer of the stomach consists of simple columnar epithelial cells. This is the epithelial layer of the stomach shown in this slide here. These cells are simple columnar epithelial cells in contrast to the stratified squamous epithelium we saw in the esophagus. On this slide, you can see the muscular layer of the mucosa here, and everything between the muscular layer and the epithelium is the lamina propria. The two histologic hallmarks of the stomach are the presence of gastric pits and gastric glands. These are the gastric pits, these invaginations of the mucosa, as I'm drawing my arrow at here. The gastric glands are found in here. These are ducts lined by cells which secrete gastric juice into the lumen of the stomach. And many of the cells that are important for gastric physiology are found in the gastric glands. So you can find parietal cells which make acid. Parietal cells are pink. These are parietal cells here. They secrete acid into the base of the gastric pits. Chief cells are found in the glands of the stomach. They make pepsin. Mucous neck cells are found in the glands of the stomach. They make mucus. And then you can also find the G cells in the antrum of the stomach that make gastrin. On this slide, I've zoomed in on the picture from the last slide so that you can see the gastric pits here lined by simple columnar epithelial cells. You can see the mucosal layer of the stomach here. You can see pink parietal cells here and dark blue or purple chief cells down here at the bottom. Shown on this slide is a drawing of the layers of the small intestine, and many of them are the same layers we saw in the stomach. You can find a submucosa of the small intestine. You can also find a muscular layer and a serosa. There's a submucosal nerve plexus. There's also a mesenteric plexus between the layers of the muscular layer. What's unique about the small intestine is the presence of villi. These are finger-like projections that extend out into the lumen of the small intestine, and they are present to increase the surface area for absorption because the main job of the small intestine is to absorb nutrients. Also in the small intestine, you can find the presence of invaginations of the mucosa called crypts, which are much shorter than the long villi that project out into the lumen. Here's a cross-section through the small intestine. Here's the muscular layer here. This is columnar epithelium shown here, and you can see these villi extending out into the lumen of the small intestine. You can also see these crypts as I'm drawing my arrow around right here. Let's talk about some of the features of the small intestine mucosa in a little bit more detail. The first feature is the villi. Those are those finger-like projections of the mucosa that extend into the lumen. And I bolded the word mucosa because they like to ask you on your boards which layer is present in the villi, and the answer is mucosa. And these are present to increase the surface area for absorption. The other feature we saw in the last slide are the crypts. They're sometimes called the crypts of Lieberkühn, and they contain goblet cells which secrete mucus. We'll talk about the goblet cells in a minute. And then another feature you'll hear about in the small intestine is the presence of microvilli. These are microscopic extensions out from the epithelial cell membrane. You cannot see these under the light microscope. You have to use an electron microscope, and then you can see the presence of microvilli, which further increase the absorptive area for the small intestine. These are what microvilli look like under the electron microscope. You can see these projections coming out of the epithelial cell membrane. If we go back to this slide, you can't see the microvilli on this slide, but there are little tiny microvilli sticking out of these epithelial cells here. So not only do you increase the surface area for absorption by having the villi present, you then have microvilli present as well, and they add up together to create a massive increase in surface area for absorption.
Another feature of the small intestine that increases the surface area for absorption is the presence of the plicae circularis, or the circular folds. If you look at this endoscopy image of the small bowel, you see that there are these raised ridges in the small intestine. Those are the circular folds, and they increase the surface area for absorption. The circular folds go by a couple of different names. They're sometimes called the valves of Kirkring or the Kirkring folds. They're also sometimes called the valvulae conniventes. And they are folds of the mucosa and submucosa layers. I've bolded this to remind you of that. And they increase the surface area for absorption. You can find them throughout the small intestine, but they are most abundant in the jejunum. If we go back to this slide, you can see the villi, which increase the surface area for absorption. As I told you before, we also have microvilli present to increase the surface area for absorption. And now if you can imagine, this entire mucosa and submucosa layer is folded up on a ridge that is the circular folds that also adds to the surface area for absorption in the small intestine. I mentioned the goblet cells before. They are found in the small and large intestine, and they produce mucinogen, which goes on to form mucus. They increase in number from the duodenum to the ileum. The ileum has the most, and they are not normally found in the stomach, and this is important because when patients have chronic inflammation and gastritis of the stomach, goblet cells will begin to appear. This is called intestinal metaplasia, and this is a potential precursor of malignancy. Here's that cross-section through the small intestine that we saw before. These clear cells here are goblet cells. On the right, I've zoomed in on some villi, and you can see a goblet cell with an arrow pointing to it right here. Shown on the screen is a picture of a Brunner's gland. This is a gland you can find in the submucosa of the duodenum. This is the muscular layer of the mucosa. Everything up here is mucosa. This Brunner's gland is located in the submucosa. And its job is to produce alkaline or basic fluid to neutralize the acidic fluid coming from the stomach. When chyme enters the duodenum from the stomach, it's very acidic. The duodenum needs to neutralize this so that pancreatic enzymes can be effective, and also to protect the duodenum and small intestine from damage from acid. So the Brunner's glands make basic or alkaline fluid in order to neutralize the stomach acid. An important clinical correlation of the Brunner's glands is that the thickness of these glands increases in peptic ulcer disease. Peptic ulcer disease occurs when patients are exposed to excessive acid, so it makes sense that these Brunner's glands would increase in thickness and hypertrophy in order to make more basic fluid to neutralize the acid. Another structure you can find in the small intestine is a Peyer's patch. In general, as you move from the duodenum to the ileum, you find more and more lymph cells. They're found in the lamina propria of the mucosa layer. By the time you get to the ileum, there are so many lymph cells present that they aggregate into structures called Peyer's patches, which are analogous to lymph nodes. If you look at this cross-section through the ileum on the screen here, you can see a Peyer's patch has been circled in red. It lies just below the muscularis layer of the mucosa in the submucosa. Some of the epithelial cells above the Peyer's patch are specialized epithelial cells called M cells, which can collect antigen and transmit it to the Peyer's patch so that it can be processed. And in this way, the Peyer's patch serves as a lymph node, generating an immune response. And you can use the presence of Brunner's glands and Peyer's patches to tell which portion of the small intestine you are looking at. If you see Brunner's glands, and you are looking at the duodenum. If you see Peyer's patches, you're usually looking at the ileum, and in the jejunum, you usually don't find either structure present. A final structure I'll mention in the small intestine is called a lacteal. These are lymphatic channels within the villi, and they're very important for the absorption of fats. As I talk about in some of the other modules, fats are not absorbed into the bloodstream, but they are absorbed into the lymph system, and the way they get from the intestine into the lymph system is to travel via a lacteal. If you look at this picture on the right, it shows these lymph vessels running up into the villi. Those are the lacteals. If you look over at the left, you can see this white space inside of a villi that I've zoomed in on. That is a lacteal inside of a villi. Let's move on to the colon. The colon produces lots of mucus. It also absorbs fluid and electrolytes. And on histology, the hallmark of the mucosa of the colon is to see crypts without villi. This is a picture of a cross-section through the colon. You can see these deep crypts here, but there are no villi as you would see in the small intestine. There are lots of goblet cells present to produce all that mucus in the colon. You can see lots of goblet cells lining these crypts. The colon is divided up into pouches called haustra. If you look at this picture, each one of these pouches here is a haustra. You can sometimes see these on imaging. It can help you to identify the large bowel. And when you do surgical rotations as a medical student, hopefully you will be able to handle the large bowel. And when you do, you will easily be able to identify the presence of the haustra. In other modules, I talk about peptic ulcer disease and ulcers and erosions of the GI tract. These are breakdowns of the GI tract lining. They can cause dyspepsia, which is abdominal pain. They can also cause bleeding. What I want to mention in this module is that when we talk about an erosion of the intestines or the stomach, we mean a breakdown of the mucosa layer only. When we talk about an ulcer, we mean a breakdown that also involves the submucosa and potentially the muscularis mucosa. This is a picture of an ulcer on the screen here, and this type of lesion would involve the submucosa and probably the muscularis mucosa as well. I'll finish this module by discussing the enteric nervous system. As I mentioned before, there are two nerve plexuses in the layers of the gastrointestinal wall. The first one is called the submucosal plexus, or Meissner's plexus, and the second one is called the myenteric nerve plexus, or Auerbach's plexus. If we look at this picture on the screen here, I've cut away the mucosa and just started with the muscularis mucosa here. We then have the submucosa, the muscular layer, and the serosa. The first plexus, Meissner's plexus, or the submucosal plexus, is found just below the muscularis mucosa in the submucosa shown right here. The second nerve plexus, Auerbach's plexus, is found within the muscular layer between the circular muscles and the longitudinal muscles as shown right here. The major role of the submucosal plexus is to control secretions and blood flow. The major role of the outer plexus, Auerbach's plexus, is to control GI motility. Another electrical feature of the gastrointestinal tract is the presence of slow waves. These are oscillations or fluctuations in the membrane potential of GI smooth muscle cells. And I've bolded the word smooth muscle to remind you that this is a phenomena of muscle cells, not of neurons. It's sometimes a point of confusion. Slow waves originate in cells called interstitial cells of Cajal. These are sometimes called the pacemaker cells of the intestine, and these cells initiate a fluctuation in the change of the membrane potential of smooth muscle cells. What will happen is the membrane potential will slowly rise to become near threshold for depolarization. When it's near threshold, action potentials can occur and cause contraction of the smooth muscle. And in this way, slow waves help to regulate the contraction of smooth muscle cells in the wall of the GI tract. Let's look at these two pictures at the bottom of the screen here. This shows the voltage fluctuation that results from slow waves. So the interstitial cells of Cajal would initiate a slow wave, and the membrane potential of the smooth muscle cell would slowly start to rise. When it gets up high, it's very close to threshold, and action potentials can occur to cause depolarization of muscle cells. When an action potential occurs, such as I've shown here, the tension begins to rise in the smooth muscle. The slow wave then resolves, and the membrane potential falls back down to a lower level, and the tension releases. Then the interstitial cell of Cajal will initiate another slow wave, and the phenomena will repeat itself. You may be familiar with the action potential inside of neurons. I've shown one of those on the screen here. And in a neuron, the voltage starts at -70, it depolarizes, and it goes right back to -70. What's happening inside the smooth muscle cells in the GI tract is that this resting state is fluctuating. It's going up and down. Obviously, when it's very low, it's hard for an action potential to occur, and it's very unlikely that the smooth muscle cell will contract. When the voltage gets very high, it's easy for an action potential to occur, and it's very likely that the smooth muscle cell will contract. And in this way, the slow waves control the rate of contraction along the muscles of the GI tract. So what the slow waves are really doing is setting the maximum number of contractions per time within different portions of the GI tract. And there are characteristic slow wave frequencies for each part of the GI tract. In the stomach, it's about 3 per minute. In the duodenum, it's about 12 per minute. And in the ileum, it is about 8 per minute. There's really no pathologic tie-in to this. There's no disease associated with abnormal slow waves. There are no drugs that affect the slow waves. This is purely a physiology concept. This is the type of thing they are testing less frequently on the USMLE Step 1, but you should be aware of slow waves in case the question does come up. And that concludes our module on the gastrointestinal